But I thought it might be useful for you guys to know, I've alluded to this several times, the stuff I've been doing for the last 12 months with our aviation crews. So I thought I would chat through with you what I've been chatting through with them, and then we're all on the same page and you can understand what they might be expecting from you. So this was a project that started around about June time in 2022, when we had this cyclic block. And this is a picture from the sim that we did on the day when we were all there together. So paramedics, doctors, aircrew and pilots. And the sim involved a double patient scenario. So we've got the child on the floor who was in a traumatic arrest. And then we've got this deeply unwell looking person in paramedic clothing on the very far right-hand side of the screen, who was the other patient. They were meant to be brothers. And then this person squatting down is not, as you might suspect, Mick Burrow. It is, in fact, the parent of the child, if you suspend your disbelief for a moment. So this was meant to be quite a confronting sim scenario. And we got some of the medical teams who were present for this block of cyclic to go in and treat and work out how they were going to deal with a double patient scenario. And they had an aviation crew with them. This is in the CATS, so the VR simulation thing that's in the back of this room. And what happened after the sim had finished is we all went and sat down and had a debrief. And as part of the debrief, one of the aircrew officers who'd been involved in the sim, playing himself as an aircrew officer, said, well, for me during the sim, there wasn't a lot for me to do aviation wise, but the parent came up and talked to me and I just never really know what to say to parents in that scenario. And that kind of hit me in the chest for two reasons. Number one, because I had been in conversation with senior base pilot Tim Frankel 4 years ago about doing some work with our aviation crews around this stuff. And then I got pregnant and got dementia and completely forgot all about it. And so I was like, shit, I was supposed to do this years ago. And the other thing was that we kind of take for granted that our aviation crews have some sort of skill set for communicating with distressed people on scene. And I think if you're like me, you sort of assume that because they've been to war zones and they've got experience in Afghanistan, which I certainly don't have, that they know what it's like to be confronted by a lot of the stuff that we go to every day. And that when you speak to them, that just isn't the case. So what happens in the military space when they go to pre-hospital jobs is that they fly a very short distance usually to go and retrieve somebody. They do a hot load of the patient. They fly back to Camp Bastion, which is like 2 minutes flight. The patient's gone. And they see nothing from the medical side. And nobody talks to them from a kind of on-scene perspective because, number one, they're not getting out of the aircraft. And number two, if they did, it would be a hostile action and everybody's got guns and just nobody engages in conversation. Versus what they do with us, which is you land in a field and then people sort of are usually there accompanying the patient and they migrate to somebody for information, for reassurance, for all that kind of stuff. And the people they migrate to are our aviation crews because they're the people who don't directly have hands-on. And they feel, or certainly now they feel a bit better prepared, but prior to this training that we've been doing for the last 12 months, they have felt globally unprepared to be put in that scenario. So I spent 13 cyclic block weeks with the crews. I think I only missed one of the 13 sessions. And then they had a pre-recorded version of this talk. I've then been to Lismore base, to Newcastle base and Tamworth base. And most recently, I was at the Aeromedical Conference last week in Adelaide, and I did some of this training for just random pilots, aircrew officers, anyone who wanted to have it as part of the learning hub there. But what I found in those sessions was when I asked people how they felt, had it ever happened, and do people talk to you on scene? Everybody said yes. This is what happens. And I think we often don't know that it's happening because we're very busy dealing with patients. So this is happening outside of our eye line. And the very first session I ran with our aviation crews, somebody cried, recounting an experience they'd had talking to relatives on scene. And somebody with a significant amount of experience described it as the absolute worst part of the job that they do here at the toll base. They said being with distressed relatives is the worst part of the job, and I hate it. And I had no appreciation of that level of distress and sentiment being there among our aviation crew colleagues, because I think communicating with people in distress is something that we do in medicine all day, every day. We're trained from medical school as to how to speak to people who have distressing stuff happening to them, whether it's to them as a patient or their relatives, and our colleagues are being put straight into that position without any training. And the same actually is true of police. There's very little police training that happens in Australia in this domain. So there is a big burden that we've placed on them, and I have apologized to them. I apologize in every single session that we have had a skill set for this whole time that we could have helped them with and we didn't. But now they have all been trained in that. And this training is also being put in by Toll for the new starters. So everyone who comes online should be given access to this. They'll do their basic training as a pilot or aircrew officer to learn the Toll way. And then once that's finished, but before they come online, they'll get some these 2 talks. I'm probably not going to go through both of them, but I'll give you most of this one, and then I'll just tell you what's in the other one, because they kind of work parallel. One is about communication, one is about what medical teams do. So this is how I started off talking to them, which was to appreciate why they're being put in that situation in the first place. Why is it that people come and speak to them on scene? And I think the thing that we need to appreciate about people in distress is that they're looking for safety. And it's a very different mindset from the one that we have when we go to a job where we're expecting to maybe go and see, a big car crash that day. Sometimes, if we're completely honest with ourselves, we kind of hope something exciting is going to happen, particularly if you're me and nothing exciting ever happens, ever, in 3.5 years since I came back from maternity leave. 5 RSIs, not very much. But that's absolutely the antithesis of what the people that we're going to go and see are expecting. They have had a normal day where they didn't foresee this happening. And if we're talking about the relatives, they've got somebody that they dearly love or dearly care about who is in a critical situation, and it's completely turned their world upside down. And all they want is somebody in a position of leadership to make them feel safe in that situation. So they migrate to our crews because they are obviously part of the helicopter. They're wearing a uniform that has a helicopter on it. They're an authority figure in that situation, and they're going to be put in that position whether they want to or not. So this is the language I've given them, saying, look, this is going to happen to you if you're on a scene. You can, hide in the helicopter and lock the doors. People might still try to come and talk to you. And it's just about giving them some language and some ways of understanding that situation and thinking about it, and then also some escape strategies, so when it gets a bit too much, they don't feel like they have to go all in. So if you've spoken to our aviation crews, the first thing that they say when they see you is, "G'day, how's it going?" And that's the way that they've been greeting patients and relatives on scene. And one of the first things when I ask them, tell me about a time where you've spoken to a relative on scene and it's gone badly, they've been like, well, I said to a dad, "G'day, how's it going?" And he said, "It's quite shit, actually, because that's my child that's nearly dead over there." So I said to him, like, one of the first things that we can train you from the medical world is to start well. And I've given them this language from Kate Granger. I don't know if you heard of her over here in Australia as much as we heard about her in the UK. She was a palliative care registrar who had a terminal soft tissue cancer. And during one of her episodes of having a neutropenic sepsis, she was in hospital, and she noticed that lots of healthcare professionals were coming in and out of her room and interacting with her, but never explaining who they were. So she started a big campaign on social media for healthcare professionals to introduce themselves. It seems so basic and so straightforward. It's hard to believe that we're bad at doing it, but we are terrible at doing it. And mainly because we all know who each other are as well. In our workplaces, we sometimes forget to introduce ourselves. But she had this big campaign, and I said, I really like this phrase for us, because it flows naturally into an explanation of our roles. And that can help us to get into that mindset of being a professional in that particular space. Even though you've done your aviating and you're on the ground and you don't have much to do at the moment, while the medical team is off doing their thing, you are still in your professional role. So, hello, my name is Natalie May. I'm one of the emergency department consultants. Hello, my name is Lachlan Satcher. I'm one of the helicopter pilots. And I've encouraged them to think about following that with an empathy statement. So I've explained the difference between empathy and sympathy. I don't need to explain that to you guys. But just to get them into the mindset of this being somebody who's having a shit day, using a statement of empathy that doesn't put any particular emotional lens on what's happening, just recognizing that the situation is abnormal. And I do this in the emergency department. This is what I say to people in the emergency department. Even if they've got a sore finger, I'm Natalie May, I'm one of the emergency department consultants. I'm sorry to have to meet you like this. I'm sorry to meet you in circumstances like this. Because everybody who comes to the ED, generally, not everybody, 99.9% of people who come to the ED don't want to be there. And those other people, they still deserve a bit of compassion and empathy as well. But we can still appreciate that they might not want to be there. I've also been encouraging them that if they can then try to find out the person's name that they're talking to, that's actually really useful for us. If they can find out the relationship between the person that they're talking to and the person that we're treating, that's useful. And then using those names gives a feeling of empathy and a feeling that people are being listened to as well. Now, I talk very, very quickly. I don't know if you've noticed. One of the things that I've told them is that if you want to come across as being empathetic in a particular conversation, one of the key tools you have is to slow yourself right down. And that will also help us to feel less stressed, and particularly then when they feel hugely uncomfortable communicating with distressed people, encouraging them to speak slowly, to breathe, pause, to listen to what's being said, and to allow some time for silence, however uncomfortable that is hugely valuable in those situations. And I know this stuff is all basic to you, but this is not stuff that these guys and girls have been told before. One of the issues and worries that they have is that in a situation they're going to be expected to provide medical information. And I have reassured them that that is not something that happens. I've said that that's an expectation of these people who are in huge amounts of chaos. All they want to know is what's going to happen to my relative today, what's going to happen tomorrow, are they going to make grandma's 90th birthday party next weekend, what's going to happen to Christmas, what's going to happen to our amazing trip to Disneyland in March next year. And I say, we come across this all the time in the emergency department. And the phrase I use all the time is, I'm sorry, I don't know. The key to making that work is to tell them something we do know, and they can give reassurance on our behalf to say that the medical team will know you are here, and they are going to want to come and talk to you, and they're going to do that as soon as they can, but they're not going to do that at the expense of treating your relative. But the patient care is always going to come first. So expect that if they get engaged in conversations, and you may never know that this conversation has happened, that they're going to be telling people that we're going to go and try to talk to them. Now, this is one of my favorite bits to teach people. One of the key ways that we get ourselves into a knot when we're dealing with people in distress is that we try to interpret what their emotional state is for them. And there's a huge amount of emotional theory and psychology around when people are in distress, they're not able to process exactly what their own emotional state is. So they may be displaying huge amounts of external emotion, but what they're not doing, because they are flooded is the term, is being able to recognize what that emotional state is. And if you put a label on that emotional state for somebody, that's seen as directly confrontational, because that's an extra piece of information and processing that they are not in a situation to be able to deal with. So instead of saying to somebody, I can see you're very angry, which is sometimes something that they come across, or I know you're very upset, those things will just be like the straw that breaks the camel's back. They will send people over the edge. And the example I have of a way to deal with this is instead to say, I know you're having a really difficult day. So the word difficult is easy to process. It says this day is not normal. It does not say your behavior is not acceptable, because we see all manner of emotional responses and they are all valid in that acute distress situation. And so the best example I have of this in reality is the day I discovered that in my household of 3 adults, in 2 adults in my household, and we have 3 Amazon Prime subscriptions. So I'm there, and if you've ever tried to unsubscribe from Amazon Prime, you have to do it through like this online chat thing. Quite stressful. So I'm there trying to work out, and I know that like 2 of them are, one is mine from in Australia and one is mine in the UK, and there was some other account that was going out of our bank account, and I'm trying to find this out and swearing a lot. And my husband helpfully said to me, you don't need to be so angry about this. And of course I said, I'm not fucking angry about this, which of course I was. And instead, using the language, I can tell you're having a really difficult time. Is there like, how can I help you? Or I can tell you're having a really difficult time. Would you like me to assist? Do you need a cup of tea? Can I do something constructive? Do you need to take a time out? Whatever it is a bit easier to process rather than just adding an extra bit of information to someone who is completely maxed out. I have told the crews that it is okay for them to tap out of situations when it gets a bit much. I've said that you don't have to take on board all of this stuff. This is absolutely within our remit. This is what we do. We practice this stuff. We're good at this stuff. The key is not to just walk away, though, and leave somebody who's very distressed on their own and say, oh, I can't deal with you. It's about signposting what's going to happen. I'm going to go and make sure that the team knows that you're here. And that can be to us, or it can be to the senior ambulance crew. I have said they can talk to the police about it, but having now spoken to some police officers, they're not all that well trained in communication stuff, and they probably don't have the amount of insight into dealing with distressed people that we do. But essentially the crew know that it shouldn't all fall onto them. So that's literally it. It's not particularly, it's not especially groundbreaking, any of this stuff, but these crews had not been equipped with any of this prior to the last 12 months. So they now have, and this is what they have for their little quick win list. They may still have an emotional response to being put into these situations, and I've suggested them some ways of dealing with that, and that's kind of where you guys come in. So I've suggested that in post-mission debriefs, because if the patient is really, really sick, we may not get a chance to go and speak to those relatives, although we'll always try. We may never know that these conversations have happened. So I've suggested that they bring it up in the debrief and tell us if they've had a conversation with relatives on scene and tell us how it went. And we can talk about that and do some of that initial kind of hot debrief offloading. I've also suggested that if there's someone around who can listen on that conversation, and particularly where there's a pilot and aircrewman working together, that they can feedback for one another on what has worked or not worked. And that's how I do it in the emergency department. I would never, ever go and speak to a relative without a nurse present for two reasons. One, because the nurse needs to know what I'm saying about what's going to happen with the patient care, so we're on the same page. And secondly, because people just don't remember what you've said. And then the nurse, when I'm not there, the nurse can say, no, that actually clarified the information I've given. That wasn't actually what was said, it was this. So we're on the same page. But I always come out of the room and say to the nurse, did I really screw anything up there? Did I get the patient's name wrong? Like, how did it go? Was there something that I could have said differently, or that I said in a way that could have been approached that would have worked better? And then I've reiterated some of the importance of using their peer support networks to chat to people afterwards. So hopefully they will tell you that they've had these conversations. The feedback I've had so far, because the first group did go through about almost exactly 12 months ago, people have come up to me on base and said, oh, I had to go and speak to a relative on scene yesterday, and I remembered to go in and say, hello, my name is such and such a person. And they've found that because it's quite short and quite tangible, it's been useful so far. But I would encourage you to use your expertise as a communicator with people in distress to help our colleagues, because it has caused them quite some challenges in the past, and a lot of them are carrying around stories from years and years on the contract where they can tell you about awful scenarios where people have been really upset and they've been quite affected by it. Awesome. All right, so that's the first half of what I have been telling them, and I'll just put the other bit because this is slightly more cheerful. So the other talk that I've been giving them all in the same session, see if I can get through this in 10 minutes? No, 25 minutes. Is around what we actually do. And so this came from the first RSI job that I did when I came back from maternity leave, and we flew up to somewhere that was like an hour away. We were tasked to a 16-month-old who'd been pulled out of a dam, who had drowned, and CPR was in progress when we were tasked, and I thought we were going to a dead child, so I was absolutely delighted when the crews arrived on scene and said the child was breathing, was shit sats, and then by the time we arrived, there was reasonable respiratory effort, but the child was quite flat and quite tired out. So all we needed to do was get a line in, get the kid off to sleep, NG tube down, take him to Westmead. And of course, because it was then an hour along the line, the child had quite difficult access. I put a piddly little cannula in my favourite position down here, and it was a bit shit, but it did work. And I thought we'd like to have a second line. And we chatted about it, and we thought we probably should try for an IO. And we put the IO in the kid's leg, having spoken to the parents and explained it's going to look quite dramatic. It's going to sound dramatic. It really doesn't hurt that much. Put the IO in, got the child off to sleep, got them to Westmead, came back to base, sorted everything out. And then about an hour later, I was in the kitchen and I heard the pilot talking to another pilot, and he said, and then they got out this fucking drill. And I thought, oh, yeah, so maybe we didn't brief all the people on the scene who needed to be briefed about the use of the IO in that situation. So now all of the aviation crews also know about our life, limb and sight-saving procedures and the stuff we're going to do. So I'm not going to dwell too much on this. I'm just blitz through it. And this talk, you'll notice, does not have any blood, guts and gore in it. Now, there is a request from the aviation side that they would like, they still, even with all this knowledge on board, they have found some of our jobs in the last 12 months quite confronting in terms of what they've seen, and they would like some more controlled exposure to the blood and guts bit. So I'm working on putting together a talk for January cyclic block where they'll have a bit more of an exposure to what things actually look like, but that will be on the platform that's kind of been set out by what we do. So I've explained to them what cardiac arrest is, and that some of the procedures that have a little heart on them are more likely to happen in cardiac arrest. I've explained to them common stuff, big stuff, and rare stuff. So they know about RSIs. They know why we do RSIs, and lots of examples from needing to give lots of pain relief to significant head injuries to burns patients with inevitable airway collapse, all that kind of stuff. They know the basic procedure of how RSIs happen. They know that we consider RSIs to be sterile cockpit procedures, and they also know that we drill them and then we'll consider doing front of neck access, although I haven't gone too much into the detail of what that involves as yet. But we talked to all that kind of stuff. We've talked about lines and access and how we'll preferentially use a cannula if we can get one. We talked a little bit about central lines because that kind of came up, and I've told them mainly that they're going to be used in hospital, so they're not going to see them. And I haven't covered any of the in-hospital stuff in this talk because my experience is that generally they're not there for the stuff we do in hospital. They just go and have a cup of tea or, I don't know, whatever it is that they do when we're doing stuff in a hospital where there's somewhere else to go. And we talked about IOs, of course, and bones having good blood supply. Talked that we don't usually use the Cook needles anymore, that we use this lovely drill that makes a noise like a drill and is a drill and isn't as painful as we think, but it's painful to give stuff through there. I have talked about trauma lines and how we would do that usually under landmarks, so that they might see us sticking a needle into the front of someone's chest just before we arrive in the hospital. We've talked about the basics of controlling bleeding and the kind of basic principles of applying pressure, elevating parts, and restoring normal anatomy, which is what the rest of this kind of goes through. So they know about open book pelvic fractures and bleeding from the sacroiliac vessels, and that's why we want to close up the pelvis. So they'll know why we put a pelvic binder on to do that. They also know about splinting because we've talked about good blood supply to bones. We've talked about using Foley catheters to do internal tamponade and blowing up balloons when we can't get control of junctional hemorrhage. And we talked a little bit about max fax. This is the extent of it. So I've talked about putting epistats in and using dental blocks to restore the normal anatomy of someone's face if they've got big facial injuries. We've talked about thoracostomies as something that they might see. And the reason for the glass of water is because I talk about the lungs being adherent to the chest wall, like a glass is stuck to a glass table with a little bit of water. And then if you break that seal, then it can come away really easily. And that's basically how the lung works when you get a little bit of air in that gap. And so they understand the principles of why we might want to decompress a pneumothorax. They understand, hopefully, the methods we have of decompressing a pneumothorax. With that diagram, I do describe that we use a scalpel, but I haven't felt the need to show it to them as yet. And also, I've explained why we would do that pre-flight, as in the signs of tension pneumothorax being very similar to the signs of bleeding. And in an aircraft, it's very difficult for us to just determine the difference between the two, and we would therefore treat the one, and then we don't have to worry about it. Now, we talked about thoracotomies, and I've told them that mainly they're going to be road jobs. They're probably not going to see that a lot because it all seems to happen around stab central, around here. But they understand about pericardial effusions, and I kind of talk about the principle that most of the issues we run into in trauma are because things don't stretch when we need them to. And so they've all seen this echo and been able to identify that there's some fluid around it and trampoline sign. And then this is what they understand about a thoracotomy, is that it's like lifting up the bonnet of a car so that you can see all the parts underneath, and that we're looking for the heart in its bag so we can release the blood around it. We've talked about amputation in the context of it's going to be something that they're going to know about before it happens. It's not going to just happen by surprise, and that usually these patients either have an unsalvageable limb or it's mostly amputated already. Or it's completely mangled and it can't be salvaged. So basically that the patient's pain relief is going to be prioritized first. So it's not going to be something they're going to be surprised by, that they're going to turn around and find us chopping off a limb usually. We talked about escharotomy and when we might do that, and what happens with the skin underneath when we release it. And then we kind of talked a little bit about the rare stuff as well. So we've talked about hysterotomy and how that is for maternal survival rather than baby survival. And the idea being to empty the uterus. So we're reducing the uterine blood flow as well as reducing the inferior vena cava compression. We've talked about our target to do this within 5 minutes of maternal arrest, and that we'll be thinking about that if we know we're going to somebody who's in cardiac arrest beyond 20 weeks of pregnancy or trauma post 20 weeks of pregnancy. And we've talked about how sometimes it can have good results. So this is a case from Manchester Royal Infirmary, which is my first consultant job. This woman was 34 weeks pregnant, unrestrained in the back of a black cab taxi, T-boned at a junction. And hers was a she hadn't reached arrest. She was in the ED with a systolic of 60, and the obstetricians just took the baby out in ED. Didn't bother going to theatre. They had an RSI and just took the baby out, and they both survived. So I then was working in the Royal Manchester Children's Hospital as a consultant 2 years after this, seeing all the snotty kids, and the kids came in and had a bit of a runny nose, and I said, my usual, was he born in this hospital? His mum said, yes. I said, on time, normal delivery. And his mum was like, well, actually, no. I was in a car crash and he had to be cut out. And I was like, oh my God, I know who you are. So it was a really positive story, as in the child went on to go and have all the normal, snotty, disgusting illnesses that kids have in childhood. I also talked to them about how we train the procedures, because I think this is a good opportunity for them to understand how focused we can be in doing these things, so much so that we don't notice the dinosaurs going on in the background. This is the bit that always freaks them out, and this is how I know that people are still listening in this talk. When I start talking about lateral canthotomies and the idea of releasing the pressure behind the eye, with this picture of a pair of scissors that seem to defy logic. So I always feel like they look kind of gigantic, and then you consider the size of the eye and you go, oh no, actually they're really small. Anyway, I say that the scissors are not to scale in any way, however you look at it. But they understand that we might do that, but that it's not a big deal, that ophthalmologists often don't even repair these after they've been done. And then in the context that we might sometimes go to somebody with a brain injury somewhere a very long way away, I think this is more of a case for those of you who work in Orange. Otherwise, we can get them to a neurosurgeon in a normal time frame. But the other bit I throw in is that if you get stuck because of weather and you have somebody who is actively trying to die from their coning, then we might consider some brain surgery. So we talk about expanding hematomas. We talk about stuff going down holes and being sheared off and unpleasantness. And this is the only other patient image in the whole presentation. And this is a 14-year-old girl who came off a bike with no helmet on. Who I looked after. We talk about midline shift, because you can see that nicely in there. Having talked about the CSF, we talk about effacement of the ventricle, and they can appreciate that things are all a bit squashed. And they're always very proud to tell me they can tell what's wrong, where the problem is on the CT. So there you go, you could be a neurosurgeon. It's really that easy. We talk a little bit about the things that we're looking for knowing that things are going badly with head injuries, and that we don't carry equipment for this procedure, but that many rural hospitals do have a self-retaining drill, or it can be done with a Black & Decker case report type scenario, as in not very common. And there's also been a write-up of somebody doing it with an IO, but I don't think either of those two are particularly successful. So that's the stuff that they have all understood that we can do in the field, as it were. And I'm going to put that talk together for next year about what it actually looks like, so hopefully they'll be a bit more prepared. But I think it is important for us as medical teams to appreciate that if even though somebody's been in a war zone flying a helicopter, they may not have any experience of the sort of stuff that we are dealing with, and that we can be mistaken in assuming that just because they've been in places where people routinely get limbs blown off, that they have seen this stuff and that they're okay with it, and they may not be. That's a very quick whirlwind tour of the stuff I've been doing. Is there anything that you guys want to add or think I should put in for next time or want to ask about? Does it make sense? Anything? Nothing? No major omissions? Cool. Well, yeah. So I just implore you to look after our retrieval colleagues, because some of this is actually quite confronting for them. And the other interesting thing that is, when I've given this presentation, I've lied to them and said, there is a blood, guts and gore version of this talk. And if you want to see all the gory pictures, then come and find me afterwards and I'll show them to you. But I haven't put them in here because I don't want anyone to be isolated by that. And not one single person has come to me afterwards and asked to see those pictures. So I think they do also talk the talk and big themselves up a little bit. But actually, some of this stuff is quite confronting for them.
Are they all BLS trained?
They have to do currency here, so they can get involved. Yeah, so they do that in cyclic, I think, as well. But it is literally BLS. So that distinction around what cardiac arrest is, some of them are very clued up. The longer they've been here, the more stuff they tend to pick up. But even the things around understanding why traumatic arrests are slightly different, they're often interested in that, and they'll often want to have a chat about it. And opening those conversations can be quite helpful. Yeah. Any other thoughts or questions before I hand over to Sarah? Are you up first?
Scott's going to go first.
Oh, Scott's going to go first.
My experience, not with gory stuff, is that often they are really, really good at preempting what we want or need. And sometimes we turn around and the ventilator's there and the bridge is set up and they've just prepped the whole thing. So stuff that a lot of medical people, possibly in hospitals, wouldn't necessarily preempt. But I'm generally super impressed.
Yeah, I think they have a good appreciation of when we're going to want a ventilator, and I think they have a lot of knowledge around how our kit works and how things can be set up, but they may not necessarily have the underpinning knowledge of why things are happening that way. So, but they are genuinely keen to learn, and I think a lot of them have found this also quite useful in terms of understanding what might happen on the scene, and particularly because medicine is so medical. So I can't think of any other word for it, of how much we walk into medical school speaking English and then walk out speaking medicine, and we have to learn how to speak English again afterwards, or whatever language, our first language. And we can forget that they're not actually au fait with all these terms, and even just knowing that if we're saying we're going to do a thoracostomy, what that means, and that's going to mean somebody stabbing someone in the chest with some sort of sharp implement, is quite useful for them to have some framework for. Cool. Thanks, guys.